центра языка.
Значит, I will put it off because it's not very comfortable for me to do it. But of course they should be on the legs of patients. So the first precordial lead, S1, we put in the fourth intercostal space from the right side near the sternum. The second precordial lead, C2, we lead in the same point but on the opposite side, fourth intercostal space near the sternum. Как бы так. Then we как бы так. We put the C4. C4 we put at the point of apex beat about here. C3 we put in the middle of C2 and C4. Yes. C5 we put on the axillar anterior line, and C6 we put on the mid axillar line. This patient is not как бы alive, so that's why he как бы, it's not very comfortable to lay it on him, but on the real person it is okay. After that we should check the ECG, and according to the situation we will see the ECG changes. For example, if patient has an acute coronary syndrome, what changes he can have on ECG?
ST elevation.
ST elevation or ST depression, the ischemic signs. He may have only the sinus tachycardia. He may also have, for example, the blockades and so on. So the letter C at this is finished. So what it is include in it? Again, it is the skin tone assessment. Then it is the pulse on the radial arteries on the symmetry. Then we check radial and carotid pulse and count per 10 seconds. Then we check the capillary pulse, capillary refilling time, yes. Then we perform the heart auscultation. Then we perform the BP measurement, and then we check the ECG. This is the most, the largest letter among all algorithms. After that, we usually perform the disability assessment. We use the torch again, and we check the eyes reflex. If he has not any brain problem, yes, he should not have any problem with his eye reflex. After that, we perform the checking of muscle tone. We bend all his limbs one by one, and finish the letter by the glucometry. Just in all situations, the glucose level may be slightly high because of adrenal leads, slim. So you pretend that you find his apex pulsation. It is in the fifth intercostal space near the nipple, about 1.5 centimeter inside of nipple, and here is what valve? What valve? Mitral valve. Yes. Next point, in the second intercostal space, in the near the sternum, from the right side. Here, what valve? Aortic. On the opposite side, in the same points, our pulmonary artery. Tricuspid valve located in the above the xiphoid process here, and the last one point, it is ERPS point. It is point forward valve. It is additional point for aortic valve. It is located between the fourth and third point, approximately here. So the correct auscultation of the heart. Also, heart auscultation is one of the great problem for you at the exam. How we should correctly perform it? We should firstly find the apex beat, apex pulsation. Apex pulsation, apex point, it is the point where you feel the most touchable pulsation of the heart. Sometimes if patient has obesity or if woman has a huge breast, it is difficult to palpate it. So that's why we try to find it by saturation level is very low. Comparative percussion of lungs and comparative auscultation of lungs. After that, we move to the letter C, that is circulation. We started from the assessment of the skin tone. To this, we move by the palms across his body. And try to see, is his skin normal or it is not. After that, we move to the radial pulse, and we should check is it symmetrical or not. We should put the hands in this way, lay our 3 fingers on his radial artery, and try to compare the pulse between each other, between hands, on its symmetry. Normally it should be symmetrical. And after that, we should also compare the radial pulse with the pulse on carotid artery. And we should also count per 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And in reality, you should feel the heartbeat or the pulsation of the arteries. But in our cases, you will hear his the number of his pulse rate. After that, you should perform the capillary pulse check or capillary pulse refilling time. We press the finger pillow in a 5-6 seconds, and in normal the whites, and this is the end of B breathing. So B breathing includes the end of comparative percussion. In the same points, we perform the comparative auscultation of the lungs. Also, we start from the apex, and then we don't auscultate the clavicles because there is no any sound above it. We move across the mid-clavicle line. It is not comparative percussion. Comparative, it is one side, second side, one side, second side, one side, second side. You compare it. After that, from the left side, we stop because here is the heart. Heart has another sound than the lung. So that's why here we could not perform the percussion. After that, we usually move to the mid-axillary line and also perform comparative percussion at this area. And also the very common mistake that I see, it is performing the percussion of the lungs in the lateral zone, in this zone, this zone. Here there is no lungs. Here is the kidneys, maybe the intestine, but the lungs, they are at this place. Yes. And after that, we usually perform the comparative auscultation of the lungs. It is the same like percussion. I will show you again now percussion of the lungs at all apex without second finger, because the role of second finger plays the clavicle by its own. So, from the beginning again. Apex, clavicles, and then we continue to move across the mid-clavicle line, 3 intercostal spaces from the each side. In the same points, you compare it. You should this is wrong, because the correct number of knocks, it is 2. Understand? So after the apex, we should compare the normal lung sound with the pathological sound that we can get if we will perform the percussion above the clavicles. Because clavicles, it is the bone has another percussion sound, and that's why next step is in the